Assalamualaikum warahmatullahi wabarakatuh dan selamat sejahtera. Topik seterusnya pada pagi ini adalah indications of tracheostomy. Ada beberapa indications untuk kita melakukan tracheostomy. Ada yang dibuat secara emergency, ada dibuat secara semi-emergency dan ada juga dibuat secara elective. In emergency procedure is to maintain the upper airway. Contohnya, when we have upper airway obstruction, when patient has reduced level of consciousness, or when we have come into intubation difficulties. For semi-emergency procedure, the commonest indication for tracheostomy is actually prolonged intubation. Tracheostomy is also done as semi-E procedure in airway protection in patient with severe neurological injury. For example, patient with severe head injury, patient with bulbar palsy, patient with Guillain-Barré syndrome. And it is also done for bronchial toileting. Tracheostomy is also indicated as part of major head and neck surgery. For example, in cancer cases and also combined with maxillofacial surgery. So we go into details of the conditions causing upper respiratory tract obstruction. Sometimes tracheostomy is indicated in babies where they have congenital issues such as choanal atresia, laryngeal web or cyst, tracheostenosis, tracheoesophageal anomaly. Trauma can also cause upper airway obstruction. For example, severe mandibular fractures, in trauma to the larynx or trachea, irritants, corrosive burns which cause severe edema of the upper airway, trauma that cause bilateral recurrent laryngeal nerve palsy, and gunshot wound to the neck. Other conditions that cause upper airway obstructions are infection. For example, laryngotracheobronchitis, acute epiglottitis, and angioneurotic edema. Other things are like inhaled foreign body, laryngeal tumors, for example, laryngeal malignancy, and condition that cause bilateral vocal cord palsy, for example, stroke. Next is condition that cause respiratory insufficiency. In this case, we need to do bronchial toileting. First is the condition of the lung itself. For example, when patient has exacerbation of chronic bronchitis with emphysema, or patient post-operatively has pneumonia with suppression of cough. Secondly, the abnormalities of the thoracic cage itself. For example, patient that has severe chest injury with flail chest, so they will be unable to cough out, to breathe properly. Thirdly is neuromuscular disease, where nerve functions to the muscles that is involved in respirations is affected. For example, Guillain-Barré syndrome, tetanus, or poliomyelitis, severe myasthenia gravis. Another indication of tracheostomy is protection of the tracheobronchial tree, where patients have a lot of bronchial secretions but is unable to clear the secretions adequately. We have to do a lot of bronchial toileting. Patient may have overspill and aspiration if they have conditions such as paralysis of sphincter mechanism of larynx, or if the vagus nerve is paralyzed. Tracheostomy might be indicated in patient with head injury that can cause hypercarbia and hypoxia. Also, in patient with poisoning or neurosurgical procedure. Other conditions are like neurological condition that weakens the ability to clear the secretion in myasthenia gravis, Guillain-Barré syndrome, in patient with multiple fractures of the jaw and burns of the face. Okay, so we have mentioned all the indications of tracheostomy. What about the contraindications to tracheostomy? In the absence of upper airway obstruction, the only absolute contraindication for tracheostomy is either severe local sepsis or an uncontrollable coagulopathy. Relative contraindications, there are a few. Okay, the first one is difficult anatomy. So in this case, we need to wait for maybe further radiological studies or clearance from the primary team. Example would be a patient with morbid obesity, patient with lack of neck mobility, for example, patient of orthopedic neck injury, patient with known difficult intubation, patient with tracheal pathology, for example, tracheostomy, so we need to wait for the CT scan. Patient with thyroid pathology, especially those that encase the trachea, and patient with aberrant vessels. Okay. Secondly is patient with significant coagulopathy. We have to correct the coagulopathy first. Next is the patient who has a recent surgery of trauma to the neck. In this case, we do tracheostomy only after the anterior neck wound has healed. For example, patient who had undergone carotid and atherectomy, anterior cervical fixation, sternotomy, esophageal drainage, or burns that involve the neck. Another relative contraindication is a patient with potential instability. For example, patient is unable to tolerate cardiovascular or respiratory changes, such as those with unstable intracranial pressure after brain injury. So, patient has to wait a little while before we do tracheostomy. What are the preoperative preparations for tracheostomy? First of all is consent. We need to make attempts to get the consent from patient if they have the capacity to understand. The information that we need to include is, number one, the nature of the procedure, how tracheostomy is being done. Number two, the proposed benefits of doing tracheostomy. Number three, the potential hazards of doing tracheostomy, and is there any alternative to that? This is because tracheostomy is not without risk. However, nor is prolonged translaryngeal intubation. So we should emphasize the risks and benefits of these two procedures. The patients and next of kin should also be informed of the possibility of long-term tracheostomy care and the cost even when patient is discharged home, especially if they need to buy the double lumen tracheostomy. Next is on blood parameter consensus. Intraoperative and post-op complications include bleeding and poor wound healing. So preoperative optimization is very important to minimize these two complications. So before we proceed to OT for tracheostomy, these are the acceptable blood parameters that is required. Hemoglobin has to be more than 10 gram per deciliter, but in chronic anemia, hemoglobin of more than 8 is acceptable. Platelet has to be more than 50,000 per mil. Urea has to be less than 25 milligram per deciliter. INR should be less than 1.5. APTT between 25 to 35 seconds, and PT between 11 to 14 seconds. If patient is on warfarin, it has to be converted to heparin first. If patient is on subcutaneous heparin, the last dose to be withheld is 12 hours before the surgery, and we can restart heparin 6 hours after surgery. Claxin and fondaparinux will to be withheld the morning of the op. Okay, aspirin is to be withheld for 5 to 7 days. Patient on clopidogrel, we should stop for 3 to 5 days. For heparin, free dialysis prior to op. And make sure patient has blood products available in OT in case of bleeding. Okay, special operative consideration for patient with marked obesity or anatomical distortion, our conventional length tracheostomy tubes may be too short. So we need longer adjustable flange tube or tube with fixed extensions of the distal or proximal portion. So in the previous lectures, I think Dr. Siti has explained what are different types of tubes. Tube size, lengths, and special tubes should be assessed on individual patient basis. Changes may be needed at mid or end of the procedure if we find that the stoma is deeper than anticipated. and if the tip of the tube does not lie in a safe or satisfactory position. So before we start the procedure itself, the preparation for this possibility should be made beforehand. The tube tip position should be assessed by endoscopy during placement and then document. For ventilated patients with tracheostomy, we need to use cuff tracheostomy, which is non-fenestrated tube. The cuff should be of high volume but low pressure design, and it should effectively seal the trachea at a pressure of no more than 20 to 25 centimeter water. So this in order to minimize the risk of tracheal mucosal ischemia and subsequent tracheal stenosis. How do you know the size of the tracheostomy tube to be used? It usually corresponds with the ETT tube. You should have a trache tube of half size smaller and half size larger at the time of the surgery. For example, if we need to use size 7, we should have standby as 6.5 and 7.5 millimeters. Okay, that's all from me on indications, contraindications, and pre-op preparations for tracheostomy. Thank you for your attention.